Good afternoon, dear colleagues. Now we are gonna talk about high tibial osteotomy. We will talk about the patient selection because it is one of the most important things when we do this type of surgeries. Today we will discuss the basic concepts of limb alignment again. We will discuss the basic principles and goals of high tibial osteotomy. We will talk about the indications and contraindications to this procedure, and we will talk about prognosis and outcomes. First of all, let's recall again about limb axis and joint orientation angles. It is one of the most important concepts of limb alignment. We know that low limb has mechanical and anatomic axis, and the mechanical axis should go from the center of the hip to the center of the ankle joint, and it should go through the center of the knee. We also know that we have in joint orientation angles, this a little bit of valgus in distal femur and slight varus in proximal tibia. And why is it important? So for example, in this case, we can see the varus knee. And can we do a high tibial osteotomy in this case? If we do high tibial osteotomy in this case, we will restore the axis, the mechanical axis, but we will have the tilt of the joint. In this case, we will have an unacceptable result. Actually, the deformity here is in the femur. And so in this case, we need to do a femur osteotomy. The other most important concept that also was discussed is CORA, center of rotation and angulation. This is the coincidence of two lines, one perpendicular to the proximal joint, one perpendicular to the distal joint. And this point is CORA. Most often the osteotomy should be done on this level, and this will allow us to do an osteotomy without translation. If we do an osteotomy outside of the CORA, we will need to do some translation. In this case, for example, we also have a varus. The CORA is in the center of the tibia, and what if we do the osteotomy outside the CORA? So the ankle joint will be tilted. And we also can do high tibial osteotomy in this type of deformity because we can't afford to do this kind of translation, to do all joints parallel to each other. So we need to do an osteotomy in the CORA level, and it will restore the joint orientations. One other important thing is joint line convergence angle. So if all other angles are okay, but we still can have some errors, which can be attributed by knee instability, or it may be attributed to some cartilage loss in the medial side. So we need to do a stress X-ray to assess this also. And so this is very important when we start thinking about any deformity correction, to follow the basic principles of limb alignment. Let's gonna talk about high tibial osteotomy now. This is a joint sparing procedure for monocompartment osteoarthritis on the knee. This is alternative, or this procedure can probably delay the total knee arthroplasty, or it can be alternative for unicompartmental knee arthroplasty. It was first described in 1961. This was done below the tuberosity, and this procedure has high risk of non-union and not very good results. Currently proposed the osteotomy above the tuberosity, and This allowed to get better results. However, this type of osteotomy was associated with poor results in revision knee arthroplasty. So it was also very controversial. Make described the dome osteotomy in 1976, and the opening wedge osteotomy was proposed by Hernia in 1987. It is very important to remember about the mechanical axis. In normal knee, 67% of the load goes through the medial compartment, and in single leg stance, it is 75% of the load. So the goal of high tibial osteotomy is to reduce the load on the medial compartment. The best result I achieved in 3 to 6 degrees of mechanical valgus, and this is called Fujisawa point. This is from 30 to 40 percentile valgus, as shown on this screen. This is very important to assess the knee stability. In frontal plane, it may be collateral ligaments instability, it may be medial cartilage loss, it may be previous meniscectomy. And it's very important to assess the cruciate ligaments deficiency because it's may have influence on other prognosis. And what is more important, it may be affected and it may be corrected by high tibial osteotomy if we understand the concept. We need to remember about tibial slope. The normal values is 6 to 13 degrees of posterior tilt. And what we should know is that tibial slope affects the knee stability, the anterior posterior stability. And lateral closing wedge osteotomy, for example, has tendency to decrease the posterior slope. And if we decrease posterior slope in PCL deficiency, we will have deterioration of the symptoms. And the opposite is for the LCL deficiency. If we have patients with anterior cruciate ligament deficiency, we can decrease the slope and we will improve the symptoms, we will improve the stability. In patients with posterior cruciate ligament deficiency, we can do the opposite. We can increase the slope and we can improve the stability. And the slope can be corrected by plate position, so we can put it anteriorly or posteriorly. We also should remember if we want to have a normal slope to preserve it, the anterior gap is twice as smaller as the posterior gap. It is also very important to remember about types of high tibial osteotomy when we are talking about selection the procedure. We have closing wedge osteotomy, opening wedge, or we can gradually correct it with the external fixators. If we are talking about closing wedge, it is of course more stable procedure. Due to the good bone contact, we have a high union rate and we can early mobilize the patient. However, it is associated with limb shortening. We need to do a fibular osteotomy. We have a nerve injury. In patients with lateral ligament instability, we will have more problems. We will have more problems in patients with patellobia. Opening wedge osteotomy is less traumatic. We don't have disruption of tibiofibril joint. There is a lesser risk of nerve injury, and correction can be easily controlled by the osteotomy. However, there are other problems, other complications that is higher in opening wedge osteotomy. Gradual correction is very good alternative. However, it is not often patients have poor compliance with this procedure sometimes. So the patient selection is the key to success in this type of surgery. If we find the ideal patient for this procedure, we can prevent the total knee arthroplasty in the future. We have a satisfied patient. If we have a wrong patient, we will do a wrong surgery. In future, we will have a complicated knee arthroplasty. We will have other complications, and we will have an unsatisfied patient. So the most important factors that need to be assessed when we try to select the right patient is the patient's age, the BMI, the patient compliance, smoking, grade of osteoarthritis, the knee range of motion, and knee stability. The data says that 10-year survival after high tibial osteotomy is much better in patients younger than 65-year-olds. So it's 90% before 65 and just 70% after 65 years. The better survival is in patients before 55, and in patients after 55 with good functional index, the survival is also very good. The risk of complications, according to other authors, is 5 times higher after 56. But what is more important, we need to look at the biologic age, but not only chronologic. The obesity is also a very important factor. The outcomes is much worse in patients who has BMI higher than 30. On the other hand, there are some data that shows that the results are worse with patients with BMI less than 25. How it may be attributed to bias? Because these patients are more active. Grade of osteoarthritis is very important. Patients with less severe osteoarthritis will get more benefit from this procedure. And 3-compartmental osteoarthritis with medial, lateral tibial plateau osteoarthritis and patellofemoral arthritis, this is a contraindications to the surgery. Under correction to less than 5% of valgus will have 63% of failure. Patients with patellofemoral arthritis will have much worse prognosis. The knee flexion less than 90% is absolute contraindication to this procedure. And even if the range of motion is less than 120, the likelihood of worse outcomes is much higher. The knee stability is one more important factor. In primary wars, when we have just bony deformity, the results are the best. It is the best indications for open wedge high tibial osteotomy. In double varus, when we have bone deformity and ACL, PCL deficiency, the results are worse, and we often need to do a 2-stage procedure. We need to do a reconstruction. We also need to remember about tibial slope and how can it help us in our surgery. Smoking is increase the risk of non-union 4 times. In these patients, it is preferred not to do the surgery, but if we do, closing wedge osteotomy probably is preferred. And this is a relative contraindications to the surgery. The International Society of Arthroscopy, Knee Surgery, and Orthopedic Sports Medicine presented the following summary of this, the following indications and contraindications to high tibial osteotomy. And according to these recommendations, the ideal patients are those who is 40 to 60 years old, with BMI less than 30, non-smokers without any symptoms of patellofemoral arthrosis, and without any symptoms of lateral knee arthrosis. Patients with the age older than 60 or younger than 40 also may be candidate for this procedure, but we need to determine the right indications for it. Of course, children, rheumatoid arthritis, severe patellofemoral symptoms, flexion contracture more than 90 degrees, BMI higher than 40, and smokers who smokes more than 15 cigarettes a day, it is absolutely contraindications to the surgery. The systematic reviews published by Harris in 2013 showed that in 2-year follow-up, open wedge osteotomy in general has superior results to closed wedge osteotomy. How in longer follow-ups, there is no significant difference. The longest follow-up for open wedge high tibial osteotomy is 20 years, and it shows that 5-year survivorship in 5 years is 92%. It is decreased to 70% in 20 years. The negative prognostic factors are BMI more than 27, the age after 50 years, and inadequate correction. So we need to always remember right Fujisawa point. The following complications are reported in literature. There is no difference in complications between closed and open wedge high tibial osteotomy. It varies from 5 to 34 degrees according to literature. With closed wedge osteotomy, we have higher risk of nerve palsy, and we don't see it in open wedge osteotomy. The risk of infection and deep vein thrombosis is probably the same between both procedures, and it is not very high. The fracture of opposite cortex and intra-articular fractures is higher in closed wedge osteotomy, but it is better tolerated because in open wedge osteotomy, the fracture of opposite cortex is a huge problem that increases the non-union rate. And the non-union rate is higher in open wedge osteotomy. And according to literature, there is no differences between LCP plates and PADO plates. The risk of non-union is much higher in patients where osteotomy is done below the tibial tuberosity because it is a diaphyseal bone. And let's now talk about one clinical case. This is a 60-year-old patient, so it's above the age limit that we just discussed, but he is active, he's non-smoker, the BMI is 26. He complains of a pain, some moderate pain in medial knee, and we can see a stage 2-3 medial knee arthritis. And he complains of medial ankle severe pain. He reports that he had a leg fracture, some types of leg fracture 40 years ago. The WOMAX index is functional score is 86, and as was discussed that if it is higher than 45, the results above 60 is pretty good also. So we do a leg length X-ray. We can see the varus. The varus is definitely from the tibia. And so what we should do? Of course, we start with deformity planning with CORA. The CORA is much far from the high tibial side, and actually it's outside the bone. So how would we correct it? Can we do high tibial osteotomy here? Actually, yes, because we can do a double osteotomy, one above the CORA, one below, and it will help us to compensate this problem. So this is our surgical plan. We decided to do a high tibial osteotomy to correct 10 degrees in the upper tibia and 6 degrees in the lower tibia. We choose the put place to do the surgery, and this is an X-ray after the plan. We didn't still do the leg length, whole leg length X-ray, but intraoperatively, of course, it was checked with their cable, and the mechanical axis goes through a little bit lateral to the lateral tibial tubercle, which is called Fujisawa point. So the take-home messages are: we need to follow the basic principles always. We need always to analyze the deformity. We need to remember about joint stability. Patient selection is critical in this type of surgeries. We need to treat the patient, not the X-ray. We need to define the contraindication to these types of surgeries. We need to assess the risk factors, and we also always need to remember about possible complications. So the key to success is to choose the right patients, to do the right surgery for them, and to choose the right method of deformity correction. Thank you.